Hello, doctors. Again, welcome back to the rest of the cystic fibrosis guidelines from the pediatric UK guidelines, the Green Book. Now we will read the cystic fibrosis exacerbation guideline. Okay, what does it mean and how we can recognize the child when having exacerbation? Basically, it's in the form of respiratory infection or exacerbation. If unusual symptoms, like weird symptoms you have seen, for example, hemoptysis, abdominal pain, suggestive of distal intestinal obstruction syndrome, or bleeding varices, discuss urgently with the CF team. So any unusual features or any unusual symptoms that the cystic fibrosis patient presented with for you, for example, like he is coughing blood, he has a very severe tummy pain, he came in with vomiting of blood. So these all red flags, you have to discuss with the CF team. Okay, so there's symptoms and signs and details in here, like in form of increasing cough and sputum production. He is coughing more, a bit more sputum production. He has difficulty in breathing. He is losing weight and he doesn't like to eat anything, loss of appetite. He has thick or very tenacious sputum. He has very coarse crackles and crepitation. As we have mentioned before, he has hemoptysis, which is coughing of blood. What you're gonna do in this situation? So you will do the basic bloods as we have read before in the admission guidelines. So that's the full blood count, urea and electrolytes, liver function test. We mentioned them in the previous video. You can check it on the channel later. What's your differential diagnosis in these situations? So you have to think of non-cystic fibrosis bronchiectasis, bronchiectasis with underlying another causes, chronic obliterative bronchiolitis. Okay, so once he presented with you in this form, like hemoptysis, vomiting blood, weird abdominal pain, stuff like that. So you have to think about those stuff, non-CF bronchiectasis or chronic obliterative bronchiolitis, or like worsening cough, other symptoms that we have mentioned, mucus, more production of mucus, and more thick mucus as well, very bad coarse crepitation when you auscultate the chest. Okay, so what's additional admission procedure? All admissions must be discussed with the CF team. If you have decided that you're going to admit this child, you have to discuss that with the CF team. Trained nursing staff needed to needle portacath. So a well-trained cystic fibrosis nurse or a nursing staff in cystic fibrosis, they have to be involved in the insertion of the portacath. No one else. Okay, chest x-ray not performed routinely, as we have mentioned before. Request if a pneumothorax or lobar collapse suspected. Okay, so what's the immediate treatment in here? First of all, you will use IV antibiotic regime suggested following discussion with CF team. You have to make sure he is running on IV antibiotic. If no discussion possible, stop oral antibiotic and start the same IV antibiotic used during the last exacerbation. Right, so in here, it's very clear and straightforward. So this child came into you with exacerbation. he is very bad with oxygen saturation low, he's getting worse, he unstable, he keep coughing, producing sputum, tummy pain, whatever. So you have to make sure he has IV cannula in situ. You have to call for the trained nursing staff to insert portacath if he doesn't has any portacath beforehand. You start him on IV. After discussion with the CF team, if there's no chance to have discussion during that time, you have to switch the oral antibiotic to IV antibiotic according to the last exacerbation antibiotic choice. So that's what you have to do. If patient has never had IV antibiotic, give first line regime. Okay, take into account any past allergic reaction. Make sure he is not allergic to any kind of any allergies to any medications for penicillin, for example. You have to rule out any past allergic reactions. Okay, so first line regime in here in case of exacerbation, it depends on sputum culture. Sputum culture, Pseudomonas aeruginosa, Pseudomonas, you will start him on, we are minimizing this in CT, which is letter C and letter T. So that's letter C means ceftazidime, okay. That's 50 milligram per kg, 8 hourly, and tobramycin, 10 milligram per kg once daily. Okay, so he will take ceftazidime every 8 hours, okay, and tobramycin all together at the same time. Tobramycin 10 milligram per kg, 1 dose per day, given over 30 minutes. Use ideal body weight for height to avoid overdose. Okay, if no Pseudomonas aeruginosa, so you will give cefuroxime, that's 50 milligram per kg every 8 hours, right? Courses usually last 2 weeks, okay? For cephalosporin, but not tobramycin, aim to use whole vial by rounding doses, plus -% considering vial size. Okay, that's not our job. In the exam, you have to memorize the names if you can do the doses, but in practice, in your workplace, you will check the BNF as you go for the doses. Okay. So again, for the first line regime for exacerbated child, according to the sputum culture, if he has or if he is colonized with Pseudomonas aeruginosa, so that's CT, and he is symptomatic, so that's CT. Letter C stands for ceftazidime, and letter T stands for tobramycin. Okay, ceftazidime given every 8 hours, 50 milligram per kg, and tobramycin given once a day, single dose per day, that's milligram per kg, right? If there's no Pseudomonas aeruginosa in the culture, so you will give him cefuroxime after discussion with CF team. Don't forget this sentence. After discussion with cystic fibrosis team, cefuroxime every 8 hours, 50 milligram per kg. The course of the antibiotic for exacerbation will last for 2 weeks. Okay. For the nebulized antibiotic, prescribe the child routine nebulized antibiotic and administer as normal. Do not start a new nebulized treatment without discussion with CF team. Again, CF team highlighted in red, so it's very important. Do not forget it in your exam. Do not forget to mention also in your exam and in your practical work as well when you got the job and start working. Okay, oral antibiotic. Children's routine prophylactic antibiotic. should be prescribed and administered as normal during an admission, even when receiving IV antibiotic. So the prophylactic antibiotic is very important now. It should be prescribed and administered normally during the admission. He will never give up his prophylactic antibiotic, even when receiving IV antibiotic. If he is taking flucloxacillin orally, and he is got exacerbation and he got admitted and he started IV antibiotic, so he will never stop the prophylaxis. He will never stop prophylaxis, right? Bronchodilators, salbutamol by metered dose inhaler and spacer may be used before nebulized treatment or physiotherapy. Discuss that with CFT. Okay, so if this child needs to take a nebulized medication or nebulized antibiotic, so before that he will need to take the or administer the salbutamol bronchodilator before, so that we can make sure that the nebulized antibiotic will be delivered in a safe way, and we make sure that he will get the benefit, the maximum benefit from the nebulized medication that he is taking. So all of this will be discussed with the CF team beforehand, okay? Inhaled corticosteroids, there is no evidence these are of benefit. Discuss stopping with CF team. Okay, so inhaled steroids in cases of exacerbation of cystic fibrosis, there's no evidence. There's no study proving that so far. So discuss stopping that with the CFT. Tubramycin monitoring. Once the child administered tubramycin orally, as we have mentioned, is the first line treatment with ceftazidime, you have to check the level of blood level of tubramycin once daily regime. So he's taking, as we have mentioned before, tubramycin is single dose per day, 10 milligram per kg, as we mentioned before, trough level immediately before second and 8th dose. So before you give the second dose and the 8th dose, you have to check the blood level should be less than 1 millimole per liter. So the trough level should be less than 1 millimole per liter. High level need to be discussed with CFT. If you have got a trough level of tubramycin before second dose, more than 1 millimole per liter, so you have to discuss that with the cystic fibrosis team immediately. No need to determine peak. Always discuss dose or interval changes with CF team. It's not your job. You are not the one who are deciding that. So you have to discuss that with CF team beforehand and ensure level taken at correct time. Do not check tubramycin level via portacath or long line. So never check tubramycin level, trough level via portacath or a central line that he already administered tubramycin through, okay? Okay, this is the second page. We have the subsequent management of these exacerbation. Do not change antibiotic before discussing with CF team. If no chest improvement has occurred after 7 days course of IV antibiotic, consider chest X-ray. So as we mentioned before, that he will take the antibiotic for 2 weeks. If there's no any response in the first week, consider doing the chest X-ray. Okay. The oral corticosteroids. If no chest improvement after 7 days as well, of IV antibiotic, discuss with CF team about starting 7-day course of prednisolone, 1 milligram per kg per day, rounded to nearest 5 milligram. So at 7 days, we have 2 things to do. If there's no response to the 1 week of antibiotic, we request chest X-ray after discussing already with the CF team and the radiologist. The other thing that we have to do is to discuss the giving the oral course of 7 days of prednisolone, 1 milligram per kg per day with the CF team as well. As long as he has chest symptoms going on, okay? If already taken alternative day prednisolone at lower dose, review dosage needed at discharge, okay? For children with allergic bronchopulmonary aspergillosis, continue prednisolone for longer, okay? So for children, they just have chest exacerbation, they will take the oral course prednisolone for only 1 week, and then you will follow up again with them. For children who they have allergic bronchopulmonary aspergillosis, they will take the oral steroid or oral prednisolone for longer than 1 week, at least 1 month, then you start weaning gradually and add an antifungal agent, which is like amphotericin, whatever antifungal they needed, join it together with the prednisolone course. And this is very crucial, important to keep in mind. Nebulized mucolytic Dornase alpha or DNAs or hypertonic saline. Whether you give DNAs or you give hypertonic saline, it's all kind of mucolytic. They make the secretions a little bit soft. During admission, prescribe patients routine nebulized mucolytic and administer as normal. If thick secretions are a particular problem, a new nebulized mucolytic may be started or frequency of existing treatment increased. Discuss with CF team. Okay, discuss timing of these treatments in relation to chest physiotherapy with CF team and patient. Right, patient should bring their own nebulizer into hospital, so no sharing of equipment at all, as you have to apply the infection control measures all the time. So every single child has to bring his own inhalers, his own spacer, his own nebulizer with him. No sharing of equipment in the cystic fibrosis clinic, even oxygen mask should be replaced all the time. Okay, discharge and follow-up on advice of CF team. So you cannot discharge a child until you get advice from the CF team to discharge him. Self-administration of IV antibiotic home IV therapy. So it is appropriate in some patients for the IV antibiotic course to be completed at home. Patients and families must receive appropriate training and achieve the necessary competence whilst on the ward. So you have to teach the parents, families, and the child himself. He is young enough to learn how to administer his own antibiotic at home. That's very helpful, and this will make the discharge process smooth and easy. Service managed by CF team in conjunction with hospital pharmacy. Okay, discuss fully with CF team before making any change or arrangement. Okay, criteria for home administration of IV antibiotic. So you have criteria in here, whether he is eligible to take his medication at home, or if he not eligible, he will arrange he will come to his GB to administer his antibiotic over there, or to discuss with the CF nurse to visit him at home to give him his IV antibiotic. So there is criteria for home administration of IV antibiotic. What's that? CF team and ward staff happy for patient to be discharged. So once the cystic fibrosis team, the consultant, the registrar and SHOs, the CF nurse happy for this child to be discharged, and they are happy for him to administer his antibiotic at home, he can be then discharged. Okay, patient and parents entirely happy. The patient himself and the parents also happy to discharge, and they have learned how to administer the IV medication for their child at home. Okay, they are confident and competent to administer the IV antibiotic. Okay, patient and parent has been assessed before discharge by CF team. The CF team make sure that they are confident about the administration of antibiotic. Okay, parents have written guidelines and 24-hour contact number. You have to provide the parents with a written guidelines or a written plan, and 24-hour access number, emergency number to call on if they need any help. If patient considered responsible enough to self-administer IV antibiotic, important that parent or carer also has adequate instruction and guidance. Anaphylaxis kit at home and family know how to use it. It's very important because the child may get anaphylaxis to any of the ingredients of the medication. So you have to provide them as well with anaphylaxis kit at home. You have to make sure they are well trained how to use this kit. Notify CF team of any patient discharged on home antibiotic therapy so they can arrange support at home or at school if necessary. So that's not everything. So the child has a school to go, so they have to arrange a meeting with the arrange support for this child at his own home or at his school as well. Okay, CF team will visit the patient at home during his or her course of IV therapy to monitor progress. So he will have a couple of visits at home to make sure that everything is going well with him. He doesn't need any help. He doesn't have any struggles with his medications at home and stuff like that. Feedback, any concerns to CF team. So always you have to go back to cystic fibrosis team. It's the golden stone in here. It's the cornerstone in here. You cannot do anything by yourself. You have to discuss every single detail with the cystic fibrosis team. Okay, doctors, that's the end of the exacerbation, cystic fibrosis exacerbation guideline video. I wish I was helpful, this guide helpful for you in your exam, in your practice. You are already practicing. Please like and subscribe for my channel, and leave comment down below for any piece of information you would like to share with me from your practice. I will be so grateful. Thank you for watching, and bye-bye.